Okay, I'll start over then.
Thanks. So this is Mrs. Morse. She's Anna's mom, and she's an ICU nurse, and I'm going to let her introduce herself and give us a little history about her educational path and what she does every day. And thank you very much for coming.
Yeah. So, all right, like she said, I'm an ICU nurse. Career path is I started out going to high school around here, Fruitport High School. Went to MCC Community College for a couple of years, not having any idea what I was going to do with my life. So I took random weird classes like automotive mechanics and everything I could think of. And then I finally decided on nursing, which was really an awesome decision. So I went to the nursing program here, which, by the way, is an awesome program. If any of you are thinking about going into nursing, they're rated like one of the top in the state. And you don't have to have debt. So nobody cares once you're in the hospital if you have a bachelor's degree from University of Michigan or if you graduated from a community college. It does not matter a bit. And honestly, a lot of the nurses coming out of community college are better prepared for what you're going into.
Well, your class sizes are a lot smaller
Yeah.
there too.
And there's a lot less theory and a lot more hands-on.
This is how you do the job.
Exactly, yeah. So I graduated from there in 2004, and I went directly to the ICU at Mercy as a new grad. And I had no idea what I was getting myself into at the time. And I guess it was better that way, that I didn't know what I didn't know. So
I think that happens to most of us at the beginning of our career.
Right. So orientation at that time was 2 months of orientation, which is, it has changed now to 6 months of orientation. That just gives you like a basic, this is how you do the job type of thing. So after orientation, you'll take just like basic patients that aren't too terribly sick, you know. There's specialized training after that that you can do in the ICU. We do a lot of open heart surgeries, so the patients don't go to recovery room, they go straight to the ICU. So you learn how to take care of a brand new open heart patient. That's a certification. Different equipment like intra-aortic balloon pump, an Impella device, which is like it's like a pump that's situated in the valve of your heart that pulls blood from your heart and pushes it through the body. There's a CVVH, which is a continual 24-hour dialysis that you do on patients, so that's another certification that you can get. There's quite a few different things, so I do it all because I've been there forever, so that's fun. I also do charge nurse, so in that role you are basically the resource for every nurse on the unit. You place the patients, you decide who's going to take the patients, you respond to any code blues in the hospital, you respond to rapid responses, which are not yet code blues, but a lot of times progress into that. So there's a lot of running around when you're the charge nurse. So
How many nurses do you supervise as a charge nurse?
it depends on how full the unit is and how many nurses we can get. Honestly, the last 2 years, as you know, have been a nightmare. So right now, it's a 30-bed unit. We're full always. And so ideally, a nurse is supposed to have 1 to 2 patients in the ICU. And that's because they're so sick and you have to watch them so closely. A lot of times right now, they'll have 3. So also our 6th floor is also an ICU right now. So we have a total of 60 beds of ICU. I'm hoping that changes in the next couple months.
What's the percentage of patients in your ICU right now that have COVID?
I would say like 40% maybe.
Okay.
Almost all of the 6th floor is COVID related on ventilators. And then there's a few on the 5th floor ICU that also have COVID too, so watch yourself, it's out there, it's really bad.
So wearing masks is important, right, when you're close to people?
Yeah, if you're gonna be close to people, like like we went to the singing Christmas tree not too long ago, yeah, wear a mask in those situations for sure. Just so, you guys aren't really at risk all that much, you're young, we see very few young people. I think we had a 24-year-old not that long ago, but you can give it to your parents and your grandparents, and you never know how that virus is gonna act. Some people are totally fine, and some people who are healthy and don't have any comorbidities, they get affected horribly and sometimes don't make it. So yeah, just be careful with it, for sure. So, ICU, is anyone interested in nursing?
Oh, a bunch of people are.
Yeah?
Some of them aren't here. Anna, you can raise your hand, it's okay.
Anna? I'll call on her for everything.
Okay.
So,
So we have people that
ICU.
are interested in ICU nurse, we have people that are interested in ER, pediatrics, anesthesiology, OBGYN, that kind of stuff.
Okay, okay. Like nurse anesthetist, maybe? Mhm. So you need 2 years of ICU experience to be a nurse anesthetist. So you guys are aware of that. So, ICU is intensive care unit, or you'll hear it called critical care unit. So the types of patients that you're gonna get if you work in there are patients that have some sort of organ failure that is making their life at risk. So mainly your heart, lots of heart patients. So patients with open heart surgery, a severe MI or heart attack, heart failure. You'll get some neuro patients, which is not my favorite type of patient. I usually give that to somebody else.
Those are my favorite.
You love neuro? Good. Somebody needs neuro. So strokes, just the severe strokes will come to the ICU, usually ones that they have to do like a craniotomy, or we have to monitor their intracranial pressure. Those will come into the ICU as well. Then you have sepsis, that's a big one. That's an overwhelming infection, and it creates organ failure. Usually your lungs and your kidneys are the first ones to go, so.
That's what we talked about, that travels through your bloodstream.
Yep. So lots of ventilators. You'll have lung failure, pneumonia, COVID, CHF, ARDS, all those things. Anything that causes somebody to not be able to breathe, they get that breathing tube put in. And so you're monitoring the ventilators, you're monitoring labs. So let me see, I wrote stuff down so I don't forget.
Do you see any patients with burns in your ICU, or do they
We
go to
do
Grand
not,
Rapids? Okay.
we do not have a burn unit, so
Okay, so they go to Grand Rapids.
burns go to a specialized burn unit. Yep,
Okay.
that's one of the few that we don't take. We don't take anyone under 18 either, so no kids. So the difference between ICU nursing and floor nursing is huge, really. So you're focused solely on these 1 to 2 patients. Floor nursing is, you have like 5, 6, whatever. So you're running around, you know, you're passing meds, you're keeping an eye on them, doing assessments, whatever. ICU, you're doing focused, full body assessments every 4 hours.
Can you tell us what that looks like?
Oh, yeah, sure. So head to toe assessments. You're gonna start with neuros, you know, pupils. Are they alert and oriented, or are they sedated on a ventilator, you know? Do they have equal grips and push-pulls, you know, any sign of a stroke or deteriorating mental status that can be caused by all sorts of different things. Then you listen to their lung sounds. Do they sound different than they did 4 hours ago? Heart rhythm, that's something that's a continuous, you're always looking at heart rhythm.
And one
It's-
of your machines helps you with that, right?
Oh, yeah, yep. It is, they're all connected to a continuous EKG up in the room. So you can see if something changes, and it happens all the time. So you have to know what's their baseline rhythm like. Is this different than that, you know? Trying to anticipate what's going to happen next. That's the biggest thing. Like, you want to put out a fire before it starts. Because these patients are always having issues. So heart sounds, belly sounds. They'll always have a NG tube into their stomach, so you're assessing what's coming out of it, or if you're feeding them, you know, is the feeding actually getting digested? So you have to draw back, see if it's all just accumulating in their belly, or
Can
if
you
it's.
tell what an NG tube is? We haven't covered that yet.
Oh, yeah. It's a tube. It goes in through the nostril, down the esophagus, into the stomach. So you guys will get really good at putting those in. And then you can either set it to suction to continually empty their stomach, which is what you do a lot of times if they're on a ventilator, because you don't want somebody vomiting and having them get aspiration pneumonia. Or if they're there for a couple days, then you can start feeding them through that tube as well.
So when she said you don't want them to get aspiration pneumonia, so if you pulled something up and then it went down, we haven't talked about the different systems, but you guys know that in the neck there's the esophagus that goes to the tummy and then the trachea that goes to your lungs. We don't want something to go into the lungs that should have been in the tummy, because that's when you get aspiration pneumonia. You get infection because food went into your lungs. And what do we want in our lungs? Air.
Air.
Not food, not liquid.
So, the rest of the assessment, you're checking for distal pulses, edema, so lots of fluid accumulating under the skin. You didn't know what edema is.
Edema swelling, right? So we were just talking about that. And they know what distal means, don't you? Is that close to the body or far apart? Or further away? Further away, yes.
So those are the assessments that you do. The assessment really doesn't take that much of your day. You get pretty quick at, checking all the things. You're also checking constantly. These patients are on a lot of medications through their IVs. It's your job to know what the drug is, know what the drug is doing, know the side effects of the drug, and when to turn that drug up or down. So there's a lot of autonomy.
We talked about that. What does autonomy mean? Does she have a lot of independence or little? A lot of independence. But with that independence comes what? What did we talk about with autonomy? Responsibility, yes.
Yes.
Yes, she says it with a pause and a big sigh.
So can I show them some of the
Yeah,
pictures so
sure
they can
can.
see what a room looks like? So there's a patient in there somewhere. So this is one of the sicker patients. Like, you walk into the room, you see all these machines, you see all these numbers. So there's a ventilator way back here. That's a breathing tube giving them oxygen. This is connected to a pulmonary artery line, a line that goes in. It ends in the pulmonary artery, so it goes in through the right atrium, the right ventricle, and then out through into the pulmonary artery. It sits there, gives you all these different pressures, like cardiac index. That's how much is your heart pumping out. This person does not have a good cardiac index at all. We've got, this is your monitor, which every patient will have this. That's got your rhythm. You have two different examples of your rhythm. You have your arterial line pressure, so that's a constant reading of your blood pressure from a line in your artery. Oh, that's okay. This patient has it too. there's the pulmonary artery pressure, your central venous pressure, which is the pressure right before the blood enters the heart, your oxygenation, your temperature, it's all there. It's all connected to lines and cables, and these people have things coming out of everywhere. So not a lot of mobility for these people.
Right.
You are basically turning them.
And
That's
why-
all they can do.
And why does she worry, or her staff worry about turning them? What did we learn with our bed mobility and range of motion? So they don't get bed sores, yes. Because they don't need to complicate their lives any more than they already are.
Right. This is an Impella pump that I mentioned earlier. That's that little pump that sits in your heart and pushes blood out. That right there is our CDVH machine, so that is the continual dialysis. So there's calculations that you have to do every hour. How much fluid are they getting in? How much fluid are we taking off? Do some math, program that machine every hour to take off whatever the physician deemed is appropriate for them. So, what's going on in that room? You want to go to the next one? This is just a little bit more basic patient.
But look at all those screens still, and look at how many IV poles and fluids they have going in.
Yeah, lots of drugs.
So all of these are different medications that are going into the patient. This is called an IV bag, and this is an IV pole. What does IV mean? Do you guys remember? Intravenous, good.
Yep, so lots of drugs, and they do different things. And it's your job to know when they need that drug, when they don't need that drug. And you're looking at all these other things to see, when am I supposed to turn this down? When am I supposed to turn this up? Should I start another one? So there's just lots of decisions to be made. It's a lot of critical thinking.
I was gonna say critical thinking, problem solving. See how important that is?
Yeah, it's huge in the ICU, and then, so there's a trust relationship, you know, that you have to kind of earn between yourself and the doctors. It's not gonna come, I don't wanna say there's like a hazing time, but
We want to make sure you know what you know.
there's a rough patch. You don't just come right out of school and know what you're doing. So, it takes a lot of time. You'll get chewed up and spit out many times. It's good for you, you know, it's a learning experience, so.
We've also talked about how important it is to be part of the team, right? Everybody in the team has their job or their scope of practice. So you have to make sure you're practicing within your scope of practice, but with the trust of the other people on your team.
Right.
What's
Right.
this?
This is the crash cart. You guys, if you work in ICU, you will get very familiar with this red cart. There's 3 of them.
How many of you have seen that on Grey's Anatomy or another show? They love Grey's Anatomy.
I know. Yep, so you use this guy a lot. That's your defibrillator up there. When they're yelling clear, that's that right there.
Why do you have to yell clear, do you think? What are they doing to the heart? Shocking it. They're putting electricity in there, right?
Yep.
So do you want to be on a wet surface? No.
You don't want to be touching the patient doing something.
Because you'll get shocked.
You're gonna get that shock, yes.
And your heart doesn't need it.
Right, it'll do the opposite effect to your heart, so.
Ooh.
Oh, this is just a picture of our monitors. That's my friend Michelle. But
But that's a lot to keep track of. So when you're not in the patient's room, you're still monitoring a lot of things on their machines.
yes, all their information, not all of it, but a lot of it is on these screens right here. And so thankfully, we have a monitor tech. So if you're charting or something, they're always watching these screens. So if they see something start to go bad, they call you and they're like, hey, this is happening in this room. So you can get down there and check it out.
Oh, that's cool. Another member of a team, right? Not one person is going to keep these people alive, for sure.
You know,
Can you tell us what an if there is such a thing as a typical day or a somewhat typical day, like what is involved in a day when you go to work and how long you work?
I do 12-hour shifts, 7 a.m., 7 p.m. A typical day, like if a day that I'm taking patients, go in, look and see, there's a board that has your initials on it, kind of tells you what area you're going to work in. So you go to that area's report spot, and a person will go over each patient in that area and then kind of tell you what's wrong with them and how critical they are. And then you choose which patients you are going to take, whether it be one of them or two of them. And you just kind of choose based on your skill level and whatnot. So you get those patients, then you go to your nurse that had that patient, get a full report from them. And you just start your day out, bam. You want to look in the computer, you look at their physician notes, like what are they planning for this patient? It's always good to know. Well, you have to know, actually, because they're going to ask you, and you better know. You look at all their labs, see what sort of issues they're having, and if anything needs to be corrected. You look at their medications, what's due, what are they getting, and then you go in and meet the patient and do a head-to-toe assessment and just get started. Putting out fires, giving medications. Lasts for 12 hours.
It lasts for 12 hours. So can you tell them some of the other team members that help you take care of your patients?
Yeah. Of course, there's physicians, and there's a lot in the ICU. There's always internal medicine stationed in the ICU. So that's nice. And they have a physician assistant, and they have residents. So there's at least 3 internal medicine people always there. You have pulmonology.
What's pulmonology, you guys? Lungs.
Stop right there.
Oh.
I think this is only recording in 5-minute clips, and that seemed like a really good pause.
Okay.
So I stopped it, and I'm going to start a new 5-minute clip.
Okay. And you're on again, see?
That's funny.
So pulmonologists are what, you guys? Lungs, yes.
Lungs, yes. And with the pulmonologists, there's respiratory therapists. There's usually 3 of them in the ICU. One of them will be assigned to your room. So respiratory therapists help with, they change all the vent settings. They're supposed to. They get mad when you change the vent settings.
So then you have to work on teamwork and collaboration and communication, right?
Right.
Do you have physical therapists ICU or not necessarily?
We do have physical therapy. They don't come to the ICU as much. It's more, well, it's cardiac rehab mainly.
Yeah.
That they do pretty much the same thing though. So yeah, physical therapy comes through. We have lab techs. A lot of the times ICU draws your own labs though, so we don't see them too often. What else is there?
But they're sending their labs to somebody, so somebody's working in a lab somewhere to send that information back so Mrs. Morse can make her decisions based on what's going on with the patient's blood. And the patients have already seen billing and all of that because they probably came in through ER or a planned surgery.
Social work. Social work is there all the time, talking to patients or patients' family members if the patients can't talk. Just planning for what's next. Do they need help if they're going to go to another facility? Are they going to go home? You know, setting that kind of stuff up. There's palliative care, which is they kind of help talk people through end of life. If somebody's not going to make it, kind of help them make those hard decisions. There's also chaplains coming in and out. Let me think. Of course, there's all the specialties that are always there. Kidneys, nephrology, surgeons.
What's your favorite thing about your job?
My favorite thing about my job is I'm a heart person, so I love taking open heart patients. And it sounds weird, but I especially love it when I get a really, really sick open heart patient. So
Because you see it as a challenge, right?
yes, it's fun, I guess. So, if an open heart patient is doing really bad, and there are times, rare times thankfully, but there's times when they have to open up the chest in the room, the surgeon does. That is my favorite day. I just love it. It's so fun. So, yeah, that would be my favorite day, is having a super sick heart patient to take care of.
And what's your least favorite part of your job?
I am not a big alert and oriented type person. So, meaning if my patient's awake and they can use the call light every 5 minutes, I want them out of the ICU. Like they gotta go. They're too healthy for me. So it's, you know, it's just kind of mundane, you know, like.
You want the big challenges.
Right, like, okay, you need a glass of water. Okay, you need your pillow fluffed. Like, that's time to go somewhere else now.
Anna, I think your mom's an adrenaline junkie. She likes the rush of the challenge. So what questions do you guys have for Mrs. Morse? Jillian?
So if you keep mentioning that you love the challenge, so why did you become a nurse and maybe not like a surgeon?
Oh, because as a surgeon, I would be in school until like 5 years ago, probably. So,
And did you go to school while you had a family, before you had a family?
no, it was before I had a family.
Okay.
Yeah.
Annika?
If you were an ICU nurse, what would you be?
I would be, if I weren't an ICU nurse, I would be a physician assistant for a cardiothoracic surgery team. So,
I was gonna say younger.
oh.
What other questions do you guys have? Kayla?
Were you scared to go into the ICU as a new grad? And like, do you recommend it to like us when we go to school?
I wasn't scared going into it. However, I should have been. But like I said, I had no idea what I didn't know, so I didn't know what there was to be afraid of. So now I'm scared for other people coming into the ICU, like new grads. But I do think that it's possible, and I would recommend maybe like a year of floor nursing first, just to kind of get your feet under you before you start something like that. But I would recommend going into the ICU after this pandemic. Don't do it now.
Everything in nursing is a challenge, but ICU seems like it's just beyond anything that you could imagine.
Yeah, it's a rough situation in there right now. They get burned out like in a month and quit nursing altogether.
So what do you do to practice work-life balance or your own self-care?
I work part-time,
Okay.
and that is huge. We've lost probably 70% of our experienced staff in the past couple of years, just from burnout. And so, I think working part-time for me is what does it. Like the nice thing about nursing is you can almost choose any hours that you want. You know, you can work 1 day a week, you can work 7 days a week. So it's all kind of up to you. You can find that position that suits you.
So when you say you work part-time, what kind of hours do you work?
So I work 1 day during the school week, like tomorrow.